We have, 50 minutes, which is a long, long time. So I'm going to start off with some extremely basic concepts. I'm presuming that everybody in the room has experience doing interlaminar injections and transferable injections and caudal injections. This morning we're going to go through some basic anatomical constructs, and I'm also going to talk to you about what the literature states in support of the respective techniques and practices that we all utilize for our patients. But I'm going to start off also talking about some cervical epidural injections. I'll also talk briefly about thoracic epidural injections, and I'll provide for you a framework for how you can approach your patients and make your medical decisions regarding which technique is most applicable to your respective patients. I do not have any disclosures related to this morning's educational activity. We'll start off talking about basic things, and so please don't be offended if this anatomy is beneath you. It's just a very, very quick overview and refresher. We know we have 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral vertebrae. The body, the vertebral body, is actually a bony arch which consists of 2 pedicles and 2 lamina posteriorly. At the junction of the pedicles and the lamina, we have the transverse processes. At the junction of the lamina posteriorly, we have the spinous processes. And this is obviously showing you the multiple lordotic curves of the cervical and the lumbar regions. Each vertebra, this is a typical thoracic vertebra, this is a T9 vertebra, has several important anatomical processes to consider. We have our spinous process, we have our lamina, we have our superior articulating process and pedicle. Of course, here's the pedicle right over here. This is our vertebral foramen, and this is the vertebral body itself. The spinal canal extends all the way from the foramen magnum down to the sacral hiatus. And in addition to the spinal cord, we have meninges, 3 meninges, from innermost to outermost. We have the pia mater, the arachnoid mater, and the dura mater. The cord extends from the medulla oblongata and typically extends all the way down to the L1, L2 vertebral disc space. Well, how often does that happen? In about 88% of individuals. How do we know that? Because in 1944, 2 Northwestern University pathologists named Anson and Ryman published their findings in the Anatomical Record, which was a journal which was very popular at the time in the 1940s. And what did Anson and Ryman do? Well, they dissected 1,001 consecutive adult cadavers and found that the spinal cord ends at L1, L2 disc space 88% of the time. Now, why is that important? Because in 12% of individuals, the spinal cord is either going to end more cephalad or more caudad. Perfect case in point was a case that I was intimately familiar with that happened at Northwestern about 15 years ago, where an anesthesiologist was performing a combined spinal epidural on a patient. The patient was a retired orthopedic surgeon. The orthopedic surgeon, retired, was having a hip arthroplasty procedure, and his son happened to be an anesthesiology resident in the same program at at Northwestern University, where this case was ongoing. So the anesthesiologist put the needle in. He thought he was at L3-4 and had a paresthesia to the lower extremity. But he persisted in injecting his local anesthetic bupivacaine because he figured he was at L3-4. He must be below the termination of the spinal cord. And what happened to that retired orthopedic surgeon? Well, they went on to do the surgery uneventfully. And when he went to the recovery room, he couldn't move his legs. They sent him down for an immediate MRI of the thoracic and lumbar spine, and he had actually infarcted. He had a syrinx from the injection, which also caused an infarction of the cord. Now, why? Because his spinal cord did not end at L1, L2. So we take it for granted all the time that every spinal cord is going to end at L1, L2, but in point of fact, the spinal cord ends at L1, L2 only 88% of the time. A very important concept. Take this into consideration. We also know that our classical landmark of the intercristal line or Tuffié's line, where we put our hands on the patient's iliac crest and we draw an imaginary line across the middle of the back, we assume that indicates the L4, L5 intervertebral segment or space, but in point of fact, that's only true about 75% of the time. So these are things that we take as dogma, but we must always be looking at every individual on a case-by-case basis. At the cauda equina, of course, is the lower lumbar and sacral nerve roots, which extends for several segments. From innermost to outermost, we've got the pia mater. The pia mater is invested to the spinal cord, and that's where we find our blood vessels, primarily our anterior and posterior spinal arteries. The arachnoid mater is next, if we were to place a needle through the epidural space and through the arachnoid mater, through the dura, through the arachnoid mater, we could be doing a subdural injection. And so subdural injections are unique because the medication tends to spread in a very diffuse pattern, more cephalad than caudad, and provides a patchy level of analgesia. The dura mater is the outermost layer, is actually 2 layers invested and tightly held together side by side, and it ends at S2, but once again, the termination of the dura mater is not always at S2. It differs between adults and pediatric patients, and it can end anywhere from L5 all the way down to S5. Very important concept as well. If you're doing caudal injections and you place your needle through the sacral hiatus at the sacrococcygeal ligament, and you are assuming that you can't get a wet tap, well, in point of fact, you can very easily get a wet tap in certain individuals. And this demonstrates, this is a cat cadaver demonstrating the investment of the pia mater to the spinal cord. And you can see the blood vessels, the anterior spinal artery right here, invested between the pia mater and the cord itself. We've got 31 pairs of spinal nerves, 8, 12, 5, 5, and 1. And that's important to know as well, that these are the unification or the union of the dorsal and the ventral spinal rami, and these are mixed nerves. And after they become ensheathed by the dura arachnoid, distal to the DRG. I just reviewed a very interesting medical legal case of an individual who was doing an intercostal nerve block, and the individual placed the needle closer than 8 centimeters from the dorsal root ganglion, injected absolute alcohol. And what do you think the outcome was? Well, the absolute alcohol was actually in a dural cuff and spread directly from that dural cuff to the spinal cord, causing immediately and permanent and irreversible paraplegia. So remember about these dural cuffs, that they can extend for up to 8 centimeters past the dorsal root ganglion. This is just a demonstration of our 31 pairs of spinal nerves. There is an arterial blood supply to the spinal cord. Many of you are familiar with it. 4 basic sources: for the vertebral, the deep cervical, the intercostal, and the lumbar arteries. Somewhere between T8 and L1, typically on the left side, but not always, we find the artery of Adamkiewicz, which supplies the lower 2/3 of spinal cord blood flow. So it's only in 75% of cases do we find the artery of Adamkiewicz between T8 and L1. In some cases, it will extend as caudad as L5. There's also a very small contribution to the cord known as the artery of Desproges-Gauderon, which is typically found at L4 or L5, and which can be implicated in cases of paralysis associated with lumbar transforaminal injections performed at the lower lumbar segment, the artery of Desproges-Gauderon. And this is a representation of the blood supply to the spinal cord with the 4 respective sources. You see that there is almost always 1 anterior spinal artery and up to 2 to 4 posterior spinal arteries. And that has grave implications. Where there's only 1 anterior spinal artery, if you cause some type of thrombus or embolic process or even vasospasm of the anterior spinal artery, you can have a patient who has painless paraplegia. There is no overlap, there is no redundancy in the system as we see for the posterior spinal arteries. This is a depiction of both the blood supply, the arterial supply, as well as the venous outflow from the cord, and this demonstrates where the major vessels are in the epidural space, the venous vessels, after the yellow ligament or ligamentum flavum passing through the, placing a needle through the ligamentum flavum into the epidural space, which is a potential space laden with adipose tissue and blood vessels. This shows you from outermost to innermost the layers that must be traversed when we do either a spinal or an epidural block: the skin and the subcutaneous tissues, the supraspinous ligament which tethers the spinous processes, the interspinous ligament between the bases of the spinous processes, and then the yellow ligament or the ligamentum flavum. Passing this will of course place us into the epidural space. So let's talk a little bit briefly about cervical epidural steroid injections. As you know, the epidural space becomes wider. The more caudal we extend is typically about 1 to 2 millimeters in its greatest aggregate dimensions from posterior to anterior. C7 to T1 or C6 to C7, those are the typical areas and spaces that we place our needles in for cervical injections. Does that mean that it's negligent to place a needle at C5, C6? It depends on what you read. There's a lot of latitude, and the standard of care is broadly defined. I'm actually defending an individual right now who had a case of paraplegia from placing a needle at C5, C6 and injuring the spinal cord. However, the defense of that is that the patient had 4 prior injections, all uneventful, also at C5, C6. However, most standard references will strongly recommend not placing your needle above C6, C7. You have multiple ways to gain access to the epidural space, loss of resistance, hanging out, and so forth. My personal preference is to use the loss of resistance with saline technique. And the reason why I typically use saline is because saline tends to abut or push the dura away from the advancing needle, in my experience, to a greater extent than does air. Fluoroscopy is mandatory, and not just anterior, posterior, but also lateral imaging to assure that your needle is in the dorsal aspect of the epidural space. This is an old reference, but I always go back to it. The Anesthesia Patient Safety Foundation, which was started by Robert K. Stolting. Robert K. Stolting was the chief of anesthesia at Indiana University School of Medicine for almost 40 years. And before that, his father, Kenneth Stolting, was the chief of anesthesia. So the Stolting father and son combination ran that department for about 60 years. And the Anesthesia Patient Safety Foundation, in the fall of 2005, published 7 case reports of paralysis associated with cervical interlaminar epidural steroid injections. And what was the commonality in all 7 of these cases? Does anybody know? What was the one factor that was unique to every single one of these cases? Well, the unique factor in every one of these cases of paralysis was that the patient received propofol in addition to other chemicals, typically midazolam and fentanyl. All these patients received sedation in these 7 cases of paralysis. Now, that doesn't mean, of course, that you ought not to use sedation. That's a subject of some discussion. ASIPP has published guidelines on the safe and effective use of sedation for interventional pain management procedures, and I encourage all of you to avail yourself of that reference. So let's look at this very, very extremely important document, which was published in the esteemed journal Pain Physician some 6 years ago, and is constantly being updated. And this is an incredible body of work with 2,424 references, 2,424 references. I've never in my entire career of 36 years ever encountered a paper so thoroughly researched. And this is stated an update of comprehensive evidence-based guidelines for interventional techniques in chronic spinal pain. And so this looks at all the evidence, basically, that's ever been published on all the respective techniques that each of us in this room use and avail our patients of on a regular, routine, and ongoing basis. So let's start off now with cervical injections. And this is really what the take-home message is. I'm going to summarize it on the next slide. Evidence in favor of cervical spine interventions, that is good to fair evidence, includes diagnostic facet joint nerve blocks, that is medial branch nerve blocks, not intra-articular injections. I can't tell you how many times I'm asked to review cases in the community out in the Chicagoland area where I practice, where individuals place needles into the articular space doing cervical or thoracic or lumbar injections. Note that the evidence is in favor of blocking the nerves, but is very limited for blocking the joints. That doesn't mean you can't block the joints. It means you need to understand that the more favorable approach for making diagnostic procedures for your patients with suspected neck pain emanating from the facet joints is to block the nerves in lieu of blocking the actual joint itself. The evidence is good to fair for interlaminar epidural steroid injections in the cervical spine. Neurotomy of cervical medial branch nerves, the evidence is good to fair. And therapeutic cervical medial branch blocks, again, the evidence is good to fair. So that brings us to our algorithm about how we approach patients with neck pain. We have to determine whether that pain is somatic or radicular. And then we have many, many treatments available to us, whether we make a determination that the pain is somatic, we can do facet joint nerve blocks, we can do an interlaminar epidural injection. If it's radicular and the patient is not a surgical candidate, we can do interlaminar injections, we can do surgical disc decompression, and perhaps a spinal cord stimulator. Very important to look at the algorithmic approach, but before we accept the algorithm, we must determine whether we are contending with or dealing with a somatic process or a radicular process. This is another paper from Dr. Manchicanti and his group looking at the evidence once again for effectiveness of interventional strategies for zygapophyseal or facet joint pain, demonstrating that the evidence is level 2, which is pretty robust evidence in favor of blocking the cervical medial branch nerves. But for the interarticular injections, the evidence drops off a complete level. So that means that there's a huge variability and disparity between whether we block the cervical medial branch nerves or the actual joints. This is one of my patients who had left-sided headache pain, neck pain, shoulder pain, and all the way pain down to the hand. This is an interlaminar epidural injection in the cervical spine. My needle is ever so slightly to the left, and I've injected now 3 cc's of iodine-based water-soluble contrast, demonstrating each of these little scallops here, which is a respective nerve root, all exclusively to the left side. I do not recommend doing an off-center or parasagittal approach for interlaminar injections in the neck, but it can be done nevertheless. Make sure you always obtain and save your lateral images to determine, look how limited the depth is of that epidural space. It's 1 to 2 millimeters in its aggregate diameter. It's an extremely thin area. Your margin of safety is extremely small when you place needles in patients' cervical spine areas. So make sure you do a cross-table lateral or a swimmer's view or a full lateral, trying to reduce the imposition of the shoulder shadow to determine your greater cephalad as well as caudad spread. For thoracic blocks, remember that the angulation of the spinous processes is most caudad somewhere between T4 to T7. That means that it's very difficult, not impossible, to do a pure midline interlaminar approach. We typically do a paramedian approach, and you can read this for yourself about how a paramedian approach is conducted. That same reference from ASIPP and from Pain Physician documents what the evidence is in favor of the respective thoracic procedures. Let's go through it. So the evidence is good to fair for diagnostic facet joint nerve blocks, not for articular nerve blocks, but for the medial branch nerve blocks. The evidence is good to fair in favor of thoracic interlaminar epidural steroid injections. The evidence is good to fair for therapeutic facet joint nerve blocks. Everything else is somewhat limited. You need to avail yourself of this with 2,424 references constantly being updated. This is available to you gratis, free of charge on the website. So once again, we have an algorithmic approach to how we manage patients who have thoracic pain. First, making a determination whether we are contending with a somatic pain process or a radicular pain process. If we're dealing with a somatic pain process, we can consider medial branch nerve blocks or radiofrequency neurotomy. Discogenic pain, interlaminar thoracic epidural injections, because the evidence is good to fair. For radicular pain with no prior surgery, we can do interlaminar injections. No previous surgery, possible disc decompression, and after surgery, possible give consideration to either a stimulator or an intrathecal drug delivery system. Here's one of my more challenging patients that I placed a thoracic spinal cord stimulator in. I want you to take a look at the incredible scoliosis and lordosis that this individual had. So take a look at this curve over here. This is a Cobb's angle. That everyone knows the definition of Cobb's angle, right? More than about 30 to 35 degrees for scoliosis indicates a clear indication for surgery. However, this female is about 72 years old and was not deemed to be a good candidate, but I had to navigate this incredible thoracic thoracolumbar curve, and I was able to successfully place 2 leads. This is the first lead in her thoracic epidural compartment, and keep her from a major thoracolumbar reconstructive surgical procedure. This is an extraordinarily busy slide. I only emphasize that this comes from the same reference of Pain Physician 2013, determining the levels of evidence for the respective approaches that we all have available to us for lumbar-related conditions. And so let's summarize it. The summary of good and fair evidence: diagnostic facet joint nerve blocks. See that I keep pointing this to the same phenomenon. There's a repetitive process here where we recognize that blocking the nerves rather than the joints has greater utility and efficacy. Radiofrequency of those nerves. Diagnostic sacroiliac joint injections or cooled RFA. Caudal, lumbar, epidural, or transfemoral injections all have good evidence in their favor for radicular pain, pain with a radiating component along a segmental lumbar nerve, in favor of all the 3 techniques, whether you choose an interlaminar technique, whether you choose a transfemoral technique, or whether you choose a caudal technique. However, for discogenic or axial pain, we see that transforaminal injections are not represented. And for failed back surgery syndrome, we see that only caudal techniques are referenced. Now, many of us would say, well, here's a patient with a surgical scar. I know I don't want to do an interlaminar injection because I don't want to go through that surgical scar. I'll do a transforaminal injection. That must be evidence-based and weighted. In point of fact, caudal injections have good to fair evidence in support of their utility for failed back surgery syndrome, but neither interlaminar nor transforaminal injections have the same level of evidence. For spinal stenosis, all three techniques. For therapeutic medial branch blocks, percutaneous adhesiolysis, and lumbar provocation discography, the evidence is good to fair. Please read this article. Please download this article. Please avail yourself. When you're confronted with insurance companies that don't want to reimburse you or support you or authorize a technique or a procedure, having this document readily available and able to support your argument in favor of your patients is enormously beneficial. So what is the evidence limited for? The lumbar spine, diagnostic selective nerve root blocks. The surgeon says, I'm considering doing a fusion on this patient, but I don't know whether I should fuse L3-4, L4-5. Can you do a single selective nerve root blocks? Well, there's really no evidence in favor of that. For axial or discogenic pain, transforaminal injections don't have strong evidence. For failed back surgery syndrome, transforaminal injections don't have strong evidence. Pulsed radiofrequency, there's really no strong evidence. There are some great papers that came out of Europe several years ago, but the levels of evidence are actually weak. Intra-articular facet joint blocks, see the pattern. For cervical, intra-articular injections. For thoracic, intra-articular injections, and hence for lumbar, intra-articular injections, the evidence is actually either non-existent or weak. And you can read the rest of these techniques which have limited or no evidence in their favor. Some of those are things that we continue to offer our patients on a regular and routine basis. Once again, we have an algorithmic approach. First, determining whether our patients, respectively, have a somatic pain process or a radicular pain process. Based upon what we determine, we make a decision about what to offer our patients. And again, this is supported by levels 1 or 2 evidence-based medicine. Now, this is really what the conundrum is, and this is really what we have to contend with when we make decisions about using an interlaminar or transforaminal injections. So an interlaminar injection can be midline over here, or it can be a parasagittal off-center injection. The target, of course, is the area of nociception, where we have the vertebral body and the intervertebral disc, which is laden with chemicals. What are those chemicals? Those chemicals are mediators of inflammation. They are nociceptive types of chemicals, of which there are 7. Histamine, lactate, bradykinin, substance P, calcitonin gene-related peptide, vasoactive intestinal peptide, and phospholipase A2. So when we're doing steroid injections, what are we really trying to accomplish? Are we trying to blunt the responsiveness of the nerve root to all 7 chemicals? Histamine, lactate, bradykinin, substance P, calcitonin gene-related peptide, vasoactive intestinal peptide, or phospholipase A2. Well, 2 physiatrists in San Francisco, the Saul brothers, actually demonstrated high levels of phospholipase A2 in injured intervertebral discs. So you've got an annular tear or rent, and you've got leaking of the nucleus pulposus with high concentrations of phospholipase A2. Fortuitously, the steroid medications that we use tend to neutralize phospholipase A2. And so the concept is we want to place our medication in close proximity to the injured intervertebral disc and the exiting nerve root, which consists of both a dorsal as well as a ventral branch. And you can do that easily and efficiently, either using a transforaminal injection. This demonstrates coming in from lateral to medial, or a parasagittal interlaminar technique. And if you look at the overlap, the needles are almost superimposed one upon the other. Well, a few years back, some of my esteemed, distinguished colleagues who practice and are leaders in the American Society of Regional Anesthesia published this landmark publication in the journal Regional Anesthesia Pain Medicine, stating unequivocally that transforaminal epidural steroid injections are more effective than interlaminar injections for managing low back pain with lumbosacral radiculopathic features. And they based it upon 317 references, but their premise was somewhat flawed, respectively. They stated that, of course, the interlaminar injection always goes midline, and the transforaminal injection always captures this rent in the annulus where we have leaking of those 7 mediators of nociception: histamine, lactate, bradykinin, substance P, calcitonin gene-related peptide, vasoactive intestinal peptide, and phospholipase A2. And the premise of this article was that it's intuitive and inferential that if you place your neutralizing anti-inflammatory steroid right over the tear in the annulus, well, you're going to have a higher success rate. But it wasn't based on evidence. It wasn't based on either a systematic review or a meta-analysis of the data. This is an opinion paper, purely and simply. Of course, we know that not every interlaminar injection is created equal. There are some that go midline, and there are some that can be placed off midline to place your needle tip, and hence the medication much closer to the center of nociception. And so does that make any sense to try to go more laterally with your needle tip? Let's talk about safety. On April 23rd, 2014, the United States Food and Drug Administration issued this missive, this warning, for all physicians who performed epidural steroid injections. And they wanted you to tell your patients that epidural steroid injections can cause blindness, stroke, paralysis, or death. Okay, this came from the United States Food and Drug Administration. And they based this premise on 17 references. Well, 13 of the references were exclusive to the use of transforaminal, not interlaminar injections. And so we looked at this, myself and some of my colleagues. We had concerns about it. We thought that the message was okay, that yes, epidural injections can cause blindness, stroke, paralysis, and death. But based on their own literature, it was fake news, because basically they ought to have removed the word epidural, and everywhere the word epidural appeared or was noted to be found, they should have instead instituted the word transforaminal. So yes, epidural steroid injections can cause loss of vision, stroke, paralysis, and death, but not typically using interlaminar techniques. And so Dr. Manchicanti, myself, and several other of the members of ASIPP wrote a letter, an editorial, that epidural steroid injection safety recommendations by the so-called multidisciplinary, multi-society pain working group was more regulations without any evidence, without any substance, or without clarification. So let's go back to this. This may be the most important thing that I show you, that really our target of nociception is to place the antidote to that circulating primordial soup laden with phospholipase A2. Now, transforaminal injections are outstanding for some patients, but we must understand that here's the L3, L4 intervertebral disc. You'll see that this is where the chemical mediators of inflammation are leaching out through an injured disc. Remember, histamine, lactate, bradykinin, substance P, calcitonin, gene-related peptide, vasoactive intestinal peptide, and phospholipase A2. And our target, of course, is to neutralize the effects of those chemicals to the exiting spinal nerve root. But there is a little structure found immediately ventral to that exiting spinal nerve root, and that is the radiculomedullary artery. And so here's my take on transforaminal injections. Here I am at L4, L5. I used a curved tip needle. Remember, the nerve root is going to be right here, and typically the arterial structure is going to be cephalad and medial. So we tried to stay in the posterior part of the foramen, in the center of the foramen, and now I'm injecting under real-time live fluoroscopy, as Dr. Watanabe just talked about. And you can see here multiple segmental nerve roots, and you can see that I've spread my medication not only in the epidural space, but also along the respective nerve roots themselves. Now, several years ago, some folks up at Harvard were hypothesizing that we needed to do digital subtraction angiography for all of our patients. Digital subtraction, how many folks in the room use digital subtraction angiography? Anybody? So digital subtraction angiography is where you take a movie. It's real time. It's called cine angiography. You're basically injecting your contrast, and you heard Dr. Watanabe talk about exposure and time and so forth. There is no technique in pain management besides a CT scan that gives you higher levels of ionizing radiation than DSA. DSA exposes yourself and your patients and your x-ray techs and anybody in the room to about 10 times the fluoro dose per patient than conventional fluoroscopy does. And so they were really touting and pushing for every pain physician in the country to use DSA on every single case. Why? Because they believed that it improves safety and reduced harm to our patients when doing injections, especially transforaminal injections. So lo and behold, out of Northwestern University, about the time that this was being proposed, there was a 79-year-old gentleman who came in for a transforaminal epidural steroid injection. This is the actual DSA images taken from that injection, which happened in 2011. You'll see a needle coming in at L5S1. I've pointed arrows to several areas of interest, which there was a lot of patient artifact, there's a lot of movement, but this is what the DSA still images actually look like. So the patient had his injection of triamcinolone using a 22 gauge, 3.5-inch Quinky type spinal needle with extension tubing, with the injection of lidocaine testose. And immediately following the injection, the patient screamed out in horrific pain, clutching his chest. Well, the pain physicians suspected he was having a myocardial infarction, Sent him down to the emergency room, and the emergency room noted that he was completely paraplegic from T7 all the way caudally. This is the MRI, which was taken 2 hours after his injection. This is the T6, T7 level, and if you discern this green arrow, you can see that there's a gross edema and dilatation of the spinal cord from T7 all the way caudally. So what happened? During the performance of this L5-S1 transforaminal injection using a particulate steroid, a particulate steroid is insoluble and includes things like triamcinolone and methylprednisolone. Remember, any steroid that ends in L-O-N-E, lone, triamcinolone, methylprednisolone, that's going to be a long-acting depot steroid, but it's going to be a particulate steroid, which is insoluble. Any steroid that ends in S-O-N-E, dexamethasone, beta-methasone, that's going to be a short-acting but soluble steroid. So L-O-N-E, long-acting, particles, S-O-N-E, short-acting, no particles. So they used a drug that ends in L-O-N-E, which is a long-acting drug, triamcinolone, with particles. They injected it L5-S1, they caused an immediate infarct of the spinal cord. And that's one of several cases that I'm familiar with. So George Chen and I, he was one of my residents. He's become a huge name in interventional pain, especially for ultrasound and regenerative medicine techniques. Published several papers on the concept that digital subtraction angiography is not useful or effective for preventing errors or harm with transforaminal injections. Because we did a meta-analysis, this is not the paper, a subsequent paper. Meta-analysis showed that DSA is useful for seeing venous injection, but not useful for seeing arterial injection. So that's the safety of these techniques. How about the efficacy? So if you look again, this is from Pain Physician a few years ago, constantly updating the literature and data in support of the respective techniques. The effectiveness of interlaminar injections, 26 studies, many of them randomized, show that the evidence is good when fluoroscopy is used and interlaminar injections are used for herniated discs with radiculitis. The evidence is fair if we use local anesthetic only, or we're using these techniques for spinal stenosis or for axial pain. For transforaminal injections, again, almost the same number of studies, many of them randomized. Evidence is good when we're treating patients with herniated discs with radiculitis. It's fair, once again, if we're using only local anesthetics, because there's a body of evidence in support of using only local and no steroids. The evidence is fair for spinal stenosis, and it's limited for axial pain. This is really the most surprising thing for me. One would suspect that a transforaminal injection might be useful in patients who've got a big scar in their back, but in point of fact, that evidence exists for caudal injections only, not for transforaminal injections of steroidal medications. It's limited with the use of transforaminal injections. Caudal injections, 16 studies, so less than for transforaminal and less than for interlaminar. Evidence is good for short and long-term relief with pain secondary to a herniated disc with radiculitis. Evidence is fair for axial discogenic pain, spinal stenosis, and failed back surgery syndrome, but the evidence is better than no evidence at all. It's still better for caudal injections. Now, is there any comparison of interlaminar injections with those of transforaminal injections? Yes, there have been several papers written. We were amongst the first to do a systematic review and meta-analysis of all the data collected up to that point, looking at interlaminar versus transforaminal injections, head-to-head comparisons. People who study this phenomenon are using a prospective randomized approach, giving half the patients an interlaminar injection and half the patients a transforaminal injection. And at that point, when we published our paper, there were only about 500 patients included. Patients had no prior surgery. We found no difference in patient demographics. We followed patients for up to 6 months. These were the studies that we used for our systematic review and our meta-analysis. And what did we find? This is an important piece of information. When you're making medical decisions about what to offer your patients who've got low back pain and unilateral radiculopathic pain, do you do an interlaminar injection or do you do a transforaminal injection? So in the short term, for 2 weeks, for up to 2 weeks after the procedure, it looks like transforaminal injections actually do better in terms of reducing pain at 2 weeks. At 1 month, it's actually somewhat in favor of interlaminar injections. But at 6 months, it makes no difference at all. This is how you look at a meta-analysis. I don't want to go through that now, but you can see that this little diamond is exactly in the middle between transforaminal and interlaminar injections. It means that it makes no difference to your patients whether you do a transforaminal injection or interlaminar injection when they've got chronic low back pain with unilateral radiculopathic pain. Functionality was somewhat better in the interlaminar group, and this is the combined data at 2 weeks' time. So at 6 months, it makes no difference to your patients whether you injected them using a transforaminal approach or used an interlaminar approach. So our conclusion was that there's no clinically significant difference in efficacy, meaning how our patients do, whether we offer them a transforaminal injection or interlaminar injection. Has our data been corroborated by others? Yes, Dr. Babita Guy looked at the exact same phenomenon, comparing transforaminal injections with interlaminar injections using a parasagittal approach, and found that pain and disability were identically reduced whether those patients got a transforaminal injection or an interlaminar parasagittal injection. Have other people found the same thing? Yes, this is from Dr. Leo Capriel. Many of you know him. He was formerly at the Cleveland Clinic. Now he's in North Carolina, who looked at the same phenomenon, interlaminar versus transforaminal injections, published in the Journal of Pain Medicine, found that pain and the Oswestry disability indices were identically changed whether patients had a transforaminal injection or an interlaminar. It made no difference. So just as we found in our meta-analysis, just as Babita Guy found, Leo Capriel found the same data, that it made no difference whether your patients had an interlaminar injection or a transforaminal injection. Now, is it possible to do a unilateral epidural? That means you take an interlaminar approach and you only want to get the medicine to one side. Is that possible? Well, the great Nigel Sharrock, anyone know who Nigel Sharrock is? The great Nigel Sharrock from the Hospital for Special Surgery, who was the award winner 2 years ago from ASIPP of the Gaston Labat Award. Gaston Labat Award is given to the individual worldwide who has made the greatest contributions in medicine for regional anesthesia. And Sharrock studied 68 patients coming to the esteemed Hospital for Special Surgery in New York, and they were having unilateral joint arthroplasty surgery, either hips or knees. And he took a stimulating catheter, the same kind of catheter you might use for doing a brachial plexus block or doing a femoral or sciatic block if you do any regional anesthesia. And he put them under fluoroscopy to one side or the other, the affected side, the surgical side, and he stimulated to show that he was unilateral. He was able to place catheters in almost all patients unilaterally and get unilateral analgesia using local anesthesia. This is not steroids. This is not epidural steroids. This is local anesthetics being given for total joint arthroplasty, and Sharrock was able to demonstrate unequivocally and conclusively that you can get a unilateral epidural block, an ipsilateral unilateral epidural block using local anesthetics only. Now, we've compared head-to-head interlaminar midline, straight down the middle like you would do for labor and delivery, epidural steroid injections with parasagittal, off midline. And what did we find? The reduction in narcotics consumption was much greater in the parasagittal technique. Patient satisfaction was much greater in the parasagittal, off midline technique. Only 4% of patients, 1 out of 25, went to surgery with a parasagittal technique. I want you to remember that number. 1 out of 25 patients ended up needing spinal surgery. Their pain was better at rest, their pain was better with activity, their Oswestry disability index was better when patients had a parasagittal epidural steroid injection interlaminar versus a midline. Now, what is the bane of our existence? Harming our patients. Nobody starts out with the intent to harm their patients. We've all taken the Hippocratic oath. First, do no harm. We all believe in that. Yet and still there are individual patients who will become paralyzed by the things that we do in interventional pain medicine. Why do they become paralyzed after transforaminal injections? Well, because you've had some type of calamity associated with an arterial injury. Maybe it's vasospasm. Maybe it's an embolic phenomenon. You inject some type of insoluble steroid, long-acting steroid that ends in LONE, triamcinolone, methylprednisolone, and you cause some type of calamity to that patient's arterial structure. And this can happen anywhere. It's been reported on the left at L1, left L3, right L3, left S1, right L5S1. I've shown you all the data. And so you can see what happens. Here's an arteriogram. When you block the artery of Adamkiewicz or one of these radiculomedullary arteries, you can cause a spinal cord infarct. Now, how do we know what the factors are? Well, a very heroic doctor in New York, New Jersey area named Rick Tiso, T-I-S-O, actually was doing a cervical transforaminal injection on his own patient and paralyzed his patient. But rather than run and hide, Dr. Tiso said, what the heck happened here? It looked good. Everything that I did was standard of care. How did I paralyze this poor patient? And he went back and he took conventionally, commercially prepared steroids, including methylprednisolone, triamcinolone, betamethasone, and dexamethasone, and said, what's going on here? Is it the particles that are found in these steroids? And he subjected all of these steroids, methylprednisolone, triamcinolone, betamethasone, or dexamethasone. Remember, if it ends in L-O-N-E, it's long-acting and it has particles. If it ends in S-O-N-E, it's short-acting with no particles. And he put the steroids under a scanning electron microscope and said, what is the size of these particles? And he found out that particle size greater than 100 microns. With methylprednisolone, it's 8.6%. With triamcinolone, it's 3.7%. And it's almost non-existent with betamethasone or dexamethasone. And Rick Tizzo hypothesized that if you clog up these metarterials, if you cause an embolic phenomenon, you can actually cause an infarct by using particulate steroids. This study was subsequently repeated by Dr. Honorio Benzon, but the first person to do it, make no mistake about it, was Rick Tizzo. So I asked all of you a few minutes ago to remember that in my study of parasagittal versus interlaminar injection, 1 out of 25 patients, 4% went on to surgery. Here was another paper published about the same time by DJ Kennedy and others looking at transforaminal injections and either using triamcinolone or dexamethasone. So they said, what's better, particulate steroids or non-particulate steroids? They were trying to make a case. They were trying to advocate for the use of dexamethasone as a go-to agent for transforaminal nerve blocks. And they found that dexamethasone patients, 15% of them needed spine surgery. Triamcinolone patients, almost 19% of patients needed spine surgery. Now this is 1 out of 5 compared to our parasagittal injections with methylprednisolone, 1 out of 25. This is 1 out of 5 patients. They also found that dexamethasone, using 12 milligrams, that patients required 3 injections 7 times more likely than if they got triamcinolone. What does this mean? This means that dexamethasone is not as good in terms of reducing pain and improving functionality. Dexamethasone is not as good as triamcinolone, right? 7 times more likely that patients went on to multiple injections when they received dexamethasone compared to when they received triamcinolone. Look at the surgical rates here. These surgical rates are astronomical. I don't know about any of you in your practice, but if I was sending 1 out of 5 of my patients for surgery, that would be considered a catastrophic failure. To send 1 out of 5 patients referred to me with leg pain, with radicular pain from a disc, sending them for surgery, that's a huge failure rate in my opinion. Transforaminal injections can also cause intradiscal injections. We studied this phenomenon when I was at Northwestern. We studied 7,000 consecutive patients and looked at all the fluoroscopic images from 7,000 consecutive patients and found that a disc injection doing a transforaminal approach happened about 1 in 400 patients with transforaminal and about 1 in 4,800. So 12 times more likely with a transforaminal injection than an interlaminar injection. Doesn't mean it can't happen doing interlaminar, but it's 12 times more likely to occur with a transforaminal injection. Now also, the epidural approach is useful for other things. We'll talk about neuromodulation. I just want to mention the dorsal root ganglion stimulator. I think this is a fascinating device. How many people in the room are doing DRG stimulators? I really think that for people who have primarily foot pain or CRPS or causalgia pain in the lower extremity, placing a dorsal root ganglion stimulator, you can see it's got 4 contacts here. It's a bit technically challenging when you first start to do it, and you can see right here the DRG, the stimulator leads are situated directly corresponding to where that nerve root, dorsal root ganglion is. It's a paresthesia-less system, and the success rates are phenomenal. This is a caudal approach. If none of you have ever, has anybody in the room never done a caudal injection? Everyone using caudal injections? This is the sacral hiatus. This is where we find the termination of the epidural space through the sacrococcygeal ligament. I'm infiltrating the skin. I'm placing the needle. This is the typical angle to get into the sacral hiatus, the sacrococcygeal ligament. Now you see I'm removing the stylet from the needle. I'm placing this catheter. I tend to use catheters such as Rax catheter. I use 30 centimeter. They come in 30 and 60. I use the shorter catheter. It's a steel tip and steel styleted catheter. You can put a curve in it and direct your catheter to the right side or to the left side, depending on where the patient's symptoms are. There's a little adapter you can place on the back end of the catheter. I'm injecting contrast. This is what the lateral image looks like. Remember I told you that the dural sac may end all the way down at S5. Be careful when you're doing any caudal injection not to be too aggressive and advance that needle all the way into the sacral area, the sacral hiatus. Now there's the catheter. This shows you that I've used that steel tip and steel styleted catheter to direct it to the right side at L5S1. Here's the injection of half a cc of contrast. Here's the injection of 1 cc of contrast. Here's the injection of 2.5 cc's, and you can see multiple segmental nerve roots. And again, you can see the S1 nerve root, the S2 nerve root, and the L5 nerve root. This is the anterior-posterior view, this is the lateral view, and this is what we see with an injection in some cases. This is a catheter-less injection, just the needle itself. It looks like a Christmas tree with multiple segmental nerve roots being highlighted both on the right side and the left side. And here's our injection of our medication. This is not a lysis procedure. This is just a steroidal injection for a caudal epidural steroid injection. At the end, everything is removed and pressure is applied over the injection site. Finally, I want to finish up in the last 2 or 3 minutes that I have here. Dr. Dewan, have I gone over time yet?
You're
Okay.
fine.
So why do we choose the techniques that we choose for our patients? And I am loath to suggest that anybody is motivated by economics, but I think at the end of the day, if we recognize that interlaminar injections and caudal injections and transforaminal injections all work for our patients, right? The evidence is plain. It's been published in Pain Physician. You can go back and look at those 2,424 references. You can read it yourself. That article is about 75 pages long. But it actually should be in every one of your medical offices. So when you're dealing with insurance companies and you're having peer-to-peer reviews and you're getting a call from somebody out of state who's criticizing your medical decision making, you need to know what the evidence is in support of your medical decision making. So why are we making certain decisions? Again, I'm loath to suggest that economic fuels medical practice, but it's an undeniable fact that certain of our procedures are reimbursed at a higher rate than other of our procedures. Now, does that make sense? If all the techniques have similar or identical efficacy, why is it that certain procedures are more highly reimbursed? I'm just putting it out there. So we studied this phenomenon. We looked at Center for Medicare and Medicaid data on interlaminar versus transforaminal injections. And you can see that in the cervical spine, a lot of people are not doing cervical transforaminal injections in contemporary practice. Why not? Because there are obviously many case reports of individuals being harmed with cervical transforaminal injections. But you can see that as our baby boomers start to age and our population starts to become more septuagenarian, octogenarian, that the incidence of interlaminar injections, both for lumbar and for cervical injections, continues to rise exponentially. But nothing rises as fast as the incidence of doing lumbar transforaminal injections. We published this, myself and a few of my colleagues, in the esteemed journal Anesthesiology a few years ago, looking at the data. The greatest rate of rise of interventional pain procedures is lumbar transforaminal epidural steroid injections. And if you look at it, I'm not saying again that economics fuels medical decision making, but it's undeniable that the reimbursement for transforaminal injections is about 150% of what it is for interlaminar injections. And that's true whether we're talking Medicare, and we're talking facility fees or physician reimbursement, or we're talking Blue Cross or commercial insurance, Aetna, United Healthcare, all the other insurers. They all pay about 150% of what interlaminar injections are. So the Medicare spending, the Center for Medicare and Medicaid Services, spending for interlaminar versus transforaminal injections, the greatest rate of rise in the expenditures nationwide are for lumbar transforaminal epidural steroid injections. So in conclusion, each of the approaches that we use for our patients has benefits. I think you need to really apprise yourself of what the literature states in support of these respective techniques for your medical decision making. Vascular compromise remains the Achilles heel of transforaminal techniques, whether we're talking about cervical or thoracic or lumbar. All interlaminar steroid injections were not created equal. A parasagittal off-midline approach has been unequivocally documented and been demonstrated to have higher efficacy than a standard midline interlaminar techniques. And transforaminal really is a subject of great debate still. It's reimbursed at a substantially higher rate than interlaminar injections. But remember, the vast majority of complications of a vascular nature occur not with interlaminar techniques, but rather with transfemoral techniques. Thank you for your time and attention.
Excellent lecture as always. Thank you for your time and presentation. Now we have half an hour break because we'll come back around 9:30, I think. Or 10. We'll come back 10 o'clock.